I'm delighted today to welcome a real scientific expert in diabetes care who's on the faculty here at SUNY Downstate, Dr. Maryann Banerji. She's a professor of medicine and chief of the endocrine division, and along with colleagues, she characterized a different subtype of diabetes that's been termed flatbush diabetes or ketosis-prone diabetes. And also has been looking into insulin-sensitive and insulin-resistant subtypes and long-term remission in type 2 diabetes. So very interested to hear what she has to say about the way diabetes looks here in Brooklyn. So Dr. Banerji, I welcome you.
Well, thank you for the introduction. I'm looking for the box to stand on. But it's on wheels. So I think, so thank you very much for inviting me. And it's really a pleasure to be here. And I was there for your post-lunch event, and it seemed like there was an amazing amount of energy in that enormous public health room. So that was really terrific. So anyway, the title topic is flatbush diabetes. And these are my disclosures. And this is an outline: flatbush diabetes or ketosis-prone diabetes, the phenotype and the promise of the genotype. And so I know all of you know what's diabetes, but I wasn't certain when I started this. So diabetes is really excessive sugar. If untreated, it leads to complications, which you all know about, and that treatment of multiple risk factors improves complications. The second thing is we're a little over 100 years after the discovery of insulin, but we still have a very large number of people with diabetes, 100 million adults, 30 million who know about it and are diabetic, and 84 million with prediabetes, and about 10% plus or minus of adults in Brooklyn have diabetes. And the interesting thing to me is that the treatment of risk factors to prevent complications are variably effective. Only 21% are fully controlled after all these many years of really working at it. And so that led many of us to think that the traditional forms of diabetes, type 1 and 2, can't possibly be adequate to describe all the stuff that's going on out there in the world. And there must be a great deal of variations in diabetes or heterogeneity. Most diabetes is type 2 diabetes, over 90%. And type 1 diabetes is about 5.8%, and then there's a sliver of others, which are largely genetic. And the question is, how much heterogeneity is within the type 2 diabetes space? And one form of that kind of heterogeneity has to do with flatbush diabetes or ketosis-prone diabetes. We all know about LADA, or latent autoimmune diabetes of adults, which is another variant of type 1 diabetes. And so the focus really is on flatbush diabetes. And I start with a case from the county of 30 years ago, which is very similar to some of the cases that were described earlier in the morning, of a 48-year-old black woman whose glucose came in at 800 with a pH of 7, who was treated with insulin and fluids, had no triggering factors to precipitate this, had a family history of diabetes, and was sent home on a kind of insulin which we don't use anymore called NPH insulin, and regular twice a day. You had to mix it on your own. And she came back to clinic and had stopped her insulin, and her sugars were 90, even though we thought she was non-adherent. And 6 months later, we discovered that her A1C was 5.8 or normal. She had not lost any weight, and her BMI was 28, so she was neither thin nor very obese. And so this led to the question, 3 years later, why did she recover, and why was her A1C still normal on no medicines for diabetes, and 15 years later, she was still the same. So she had a long-term recovery after this. And I should say, incidentally, for all the plant-based people here, she did change her diet, and it turned out she had a vegetable garden in central Brooklyn, for which I used to bring her bags of manure from upstate. And we would get tomatoes in return in the summer. And so why did she recover is the question, and there's still no answer, and we're looking for it. So our little first study was 12 men and 9 women, 43 years old, blood pH of 718, which is very acidic or like vinegar. And only 2 people had precipitating factors, and 19 out of the 21 were all new onset. Our initial treatment of these patients was insulin from anywhere from 3 to 2 years, 3 months to 2 years, and they included lifestyle education. And it was brand new then at the county. It was 12 weekly classes on diet, physical activity, and medication management. And their subsequent treatments was quite varied. Some people ended up on insulin, others on sulfonylureas, and still others on diet alone. So it seems as though, in retrospect now, that we did do a lot of lifestyle education then, and if people went to class, their diabetes went away completely. And if they didn't go to class, only 5% went into remission. So something happened in those lifestyle classes. So just to summarize a lot of data, I just put it up here, and then we'll explore one or two of these, is that in flatbush diabetes, when they first come in, they don't make any insulin at all when they're sick. But their insulin secretion improves. Their insulin resistance is very common. Diabetes antibodies are absent, so they're unlikely to be type 1. Their glucose tolerance test, when you do them when they're doing well, shows either normal to mild diabetes off all diabetes medicines. And the A1C is normal or pre-diabetic. And weight loss, in this case, does not explain this phenomenon of reversal. And usually it occurs in new-onset diabetes presenting with severe DKA or hyperglycemia. Flatbush diabetes has many names. As you know, many people have many names: mom, dad, brother, sister. These are all the variations that it comes with and reflects the places of origin. The explanation for why this happens is still unknown, but this is a shopping list of what could be the causes of this, such as counter-regulatory hormones, autoimmunity, insulin deficiency, and other issues, including genetics. In analyzing people, looking at autoimmunity and residual beta cell function to try and come up with an explanation as to why this reversal happens, the group in Baylor looked at a group over there and discovered that there were really, if you presented with DKA, there were 4 different versions. The version that we're looking at are 50% of the group with negative antibodies and positive beta cell function. There are other groups in here, such as 17% have positive antibodies and negative beta cells. Those are classic type 1s. And then there are these groups in here that we really don't quite understand why they are the way they are. So there's heterogeneity built into just the DKA patients. I'm going to skip this one. And what we find also is that from the time they present, where their plasma insulins are very flat, to 3 months later, where they have a great big rise in insulin production, whether they're obese diabetics with ketoacidosis or simply obese individuals with hyperglycemia. And so in flatbush diabetes, insulin secretion improves. And that's a clear feature of it. In the Bronx, what does it mean when your new onset patient presents with DKA? 1/3 of all of DKA nowadays in the ER is type 2. And 3 out of 5 patients, or 60%, presenting with DKA as their initial manifestation also have type 2. And if you happen to be African American, obese, or older than the age of 40, the chances are even higher. 70% are type 2. So just to summarize this bit, DKA in type 2 diabetes really features the improvement of insulin secretion. Is it clinically relevant? I'm going to skip through this very fast because my time is short. And really this leads us to the notion of remission in new-onset type 2 diabetes. What would it be like if you presented with diabetes and then it all went away? And I think that's what plants do and also what this particular approach does. So we defined a remission. And we asked, how long does it last once you're in remission? And it looks like for 7 or 8 years, if you follow these patients, 50% are still in remission at 39 months, which is over 3 years with a normal A1C and no medicine whatsoever. So it's a very substantial reversal to a very stable physiologic state. And you can take this state and prolong it with a little bit of medication, such as metformin and sitagliptin, and it's better than doing nothing or giving them placebo. You can create remissions in new-onset diabetes patients by simply giving them this cocktail that we had of intensive insulin treatment and diet and exercise, and they will recover. And I'm just going to show you one slide of that. Within 3 weeks to 3 months, most of the people who are going to recover do recover if you give them this little combination of inputs. We don't quite know what all these inputs are doing. But it does happen, and we have never really developed this as a form of focused treatment of all our new-onset diabetes patients. And what you see in the process is that the insulin recovery happens very nicely with an increase in the C-peptide to glucose ratio being quite a bit higher than people who never go into remission, but they all do recover to some extent. I'm going to skip this because I'm really short of time. Glucose toxicity was shown in Japanese with DKA. The division opens and the prevalence of DKA onset in type 2 in Japanese kids increases. It's paralleled by soft drinks and vending machines and pet bottles, and nobody's changed any weight. So the question is this glucose toxicity, and is this why they develop diabetes? And this business can be switched on and switched off. This is a Turkish study of a very small number of people whom they put in the hospital for continuous insulin treatment. Some people develop remissions very early on and stay there for 5 years. Others go in and out of remission, and every time they go out, they get another 2 weeks of treatment, and then they're back in for another couple of years. And so the question really is, this can be seen all over the world, and the national societies have now decided that remission is an entity, which is a good thing. And the question is, why does it matter? From something called the Look Ahead study, which was an intensive lifestyle study, there were lower complications even if remission was transient, 40% heart disease and 40% renal disease. What's next is discovering the switch that turns diabetes on and off. And so that's the phenotype. And we're now looking for the genotype in an NIH trial to study atypical diabetes with atypical diabetes from a genetic point of view, and it's called the Radiant study, and we ask everybody out there to find people who look atypical, and they can be put in the study long distance online, sign consent, and get their genetics organized. So with that, I'm going to thank you all for listening, and have a wonderful day. Oops.
I just have one quick question for you, though.
Yeah.
So in this particular variant of diabetes, so the treatment is this short-term, like insulin, and I was just kind of wondering, what proportion of the patients that you see in the Brooklyn area falls under this category? Is this very common?
It seems very common when we're in clinic, but I really don't know the facts. And maybe we need the School of Public Health to help us figure out how to figure it out.
Yes. Thank you very much.